Welcome to the Now What podcast, a podcast focused on young adults, epilepsy, and the problems they face. I'm Sophie, your host and an advisor to the Cameron Boyce Foundation. TCBF honors the legacy of our best friend Cameron by aiming to cure epilepsy through funding research, education, and awareness campaigns while still supporting causes that were important to Cameron. In this episode, we are covering epilepsy, fertility, and reproductive health. If you are a regular listener of ours, you usually know I'm here with Kuhn. However, Kuhn couldn't make it today, so I will be joined by our incredible executive director, Heather Kuhn, who has a PhD focused in epidemiology from Harvard School of Public Health. We are incredibly excited about the conversations we're having each week, and they wouldn't be possible without our sponsor, UCB, so thank you, UCB. Now, with that being said, let's meet our guest for the week, Dr. Pak. Dr. Pak is Chief of the Division of Epilepsy and Sleep Disorders, Professor of Neurology at New York Presbyterian Hospital, Columbia. Within the Epilepsy Center at Columbia, she's the Director of the Epilepsy Monitoring Unit and Co-Director of the Epilepsy Surgery Program. One of her research focuses is on the care of persons of childbearing potential with epilepsy, and that's why she makes the perfect guest for us today. This was an incredibly informative episode for me, and as a woman, it's just empowering to have another conversation about reproductive health and how we can advocate for ourselves. So I hope you guys get something out of this. Let's get right into the episode. Thank you. Hello, Dr. Pak. Thank you so much for being here. And you too, Heather. It's very nice to have you with me today.
Very excited to join. I can't replace Karin, but I'm here.
No, I love it. It's so helpful and good to have a new face on board. So a little bit just to kind of kick us off, Dr. Pak, we would love to learn just more about how you decided to focus some of your work on fertility and reproductive concerns and working with patients in childbearing years who have epilepsy.
Well, I have to say very early in my career was, first of all, you always have to thank the people that guided you in your career choices and decisions. And my mentor was a woman who's at Stanford now, and Marty Morell, and she was very influential in this area. And I was working with her and very excited by the work she did. And at that time, it was really an error, and I can expose my age here, but it was a time when there was a lot of different newer anti-seizure medications coming on the market. And there was a lot of post-marketing work focused on individuals of childbearing potentials, looking at these medications and their impact on pregnancy outcomes. And so you had an evolution of data whereby you had these newer, so to speak, anti-seizure medications that were associated with better outcomes than some of the other medications. And so I got very interested in that. And it was very important to me to be involved in studies, really understanding that, and very important for dissemination. At that point in time, many of the providers in the community were still using anti-seizure medications for individuals of childbearing potential, like that were associated with negative outcomes, for example, valproic acid. So getting that message out there was really important to me. And so it was a time whereby there was good studies that got me excited. And then, of course, the people I was working with.
And do you think, I'm just real quick to add on to that, do you think that the field has changed since you entered for the better? Have you seen a real evolution?
I absolutely have seen an evolution. And if you look at that in terms of prescribing practices for this population, and it's not just in the US, but it's internationally. So when you look at registries, so to speak, whereby they follow individuals who are pregnant and get information about their births outcomes, the prescribing pattern has changed dramatically. So what you see is like whereby individuals before were being treated with medications that we now know are associated with negative outcomes. You don't see that as much. And you're seeing them being prescribed or taking medications that are associated with more beneficial outcomes. And another thing that I want to mention as well is that the whole culture of treating these individuals and social expectations or social life choices has changed as well. I really remember when I first started early in my practice, there was an individual, and I asked her, as part of the social history, did you have children? No, I was told I couldn't. And And this was like 20 some years ago. Well, that has changed. That cultural message has very much changed, whereby pregnancy is an option for these individuals, and people are not hearing that message anymore.
I will say that is fantastic news, but to add to the importance of the work you're doing, on our sex and epilepsy episode, one of the women who spoke said that is what she was told, was that she could not have children when she was diagnosed with epilepsy. And she's 20-something years old and still young, and luckily went to another doctor and learned otherwise. But it is amazing that we still do have misinformation. And, it's a reminder of like the forward momentum of the work.
Well, and it really highlights the work that you guys are doing with this and really continuing because, as I said, dissemination and getting that message out there to all providers was very important to me. But sometimes, that doesn't happen. And, I'm in New York, right? So there's specialized centers all over the island of Manhattan, and other people in different states may not have that. So, the work you're doing, some of the foundations that I've been involved with, and getting to the individuals themselves is a critical part of is critical. It's important to do that.
Cutting through the misinformation, for sure. Mm-hmm. Can you tell us a little bit about how epilepsy affects your chances of becoming pregnant? Just very baseline.
Yeah, no, it's a good question and a good point. And, I always like to, whenever I meet a young individual who maybe either is considering pregnancy or not, or maybe in the future, it is always something I want to talk about. And that, I got to tell you, that story has changed. When you look at older studies, pregnancy rates amongst individuals with epilepsy of childbearing potential were lower when compared to the general population. Part of that may be, as we just discussed already, the social situation in terms of, having partners. Sometimes they were less likely to have long-term partners, so to speak, than individuals without epilepsy. And also the medication profile, the medication practices, as we talked about already, have changed. When you look at some studies before, it clearly showed decreased fertility or chances of getting pregnant. Some of my colleagues, Jackie French at NYU and Paige Pinnell, who's chair at University of Pittsburgh, did a study that was published in 2016, and it looked at a population of individuals with epilepsy seeking pregnancy compared to a control population. That is, they didn't have epilepsy. And they found very similar pregnancy rates. And so that's encouraging. And then you say to yourself, well, why is that? Well, as I said already, we talked about the social piece. But the other piece is, as I talked about or mentioned, is the medications. So some of the medications that were prescribed years ago do have negative impact. They do affect your reproductive hormones, where some of the newer, more commonly prescribed medications now, particularly for, individuals of childbearing potential, don't have that same negative impact on reproductive hormones. And so I think that's why you see that. So when I'm counseling somebody, I say, very likely your chances of fertility are not going to be affected by your having epilepsy. But I do also counsel the individuals that if you're actively trying for 6 months or more, you know what, let's maybe get the infertility specialists involved sooner rather than later. But for the most part, infertility is not significantly impacted in studies and in my experience at this point in time.
That's fantastic news. That's great to hear. A little bit, if you are thinking about being pregnant, which like you just mentioned, if you're having that conversation with your doctor about when to bring a fertility specialist in, but if you're thinking of becoming pregnant, what should you ask your doctor in terms of medication and seizure control? How can patients advocate for themselves?
Well, I think, pre-pregnancy planning is so important for everybody. the general population. And I would particularly argue for individuals with epilepsy, because you want to be on the medications that have that are the most studied with the best outcomes. And we know that there are some medications that more negatively impact pregnancy outcomes. So we want to avoid those. So you want to understand, that's something you want to talk to your doctors about. Are the medications, what are the effects of the medications I'm on in pregnancy? So that's, and I know we'll be talking a little bit more about the details of that a little later, but ask specifically about the medications you're on. Or if you're on lots of medications, do I need to be on all these multiple medications? Could my seizures be controlled on less medications? Of course, it stands to reason that, or if you think about it practically, the less medication I'm on, probably the better. So, and then one thing that is important also is folic acid. So, we do recommend that individuals who are either at risk, so to speak, or actively trying to get pregnant, that they take folic acid supplementation. And so that's another thing to ask about as well. And then in terms of seizure control, seizure control is important. Most individuals, though, if they're seizure-free, so to speak, for 9 months prior to getting pregnant, will remain seizure-free. And so that is and you want to try and you want to have your seizures as well controlled as possible.
Yeah.
And the final thing that I like to leave everybody with, that I meet with, and I talk to about is, and I think it's a really important message, because so often we dive right into the risks, right? What are the problems with the medications? What are the negative outcomes? But recognize most individuals with epilepsy taking anti-seizure medications, like greater than 95%, have normal, healthy babies. And that's the message I like to leave the individuals I treat with.
Yeah, that's super important. I mean, hearing that positive outcome, you don't hear it as much, and everyone's always kind of concerned. Along those lines, I think currently you see a lot more individuals really trying to understand their hereditary or genetic risks for their child to be. Is that the case with epilepsy? Is there any genetic testing that, one can look at, or is this just a world where that does not exist?
Well, it's an evolving world, and the genetics of epilepsy is very complex. And, there are certain epilepsy syndromes, so to speak, that we know are genetically based, or there's a genetic pattern to it, so to speak. But the inheritance pattern is very complex. And so, like within my practice, there's certain what we call generalized epilepsies, like juvenile myoclonic epilepsy or childhood absence epilepsy, that we understand are genetically based. That is, their genetics of influence, they're getting that. But the clear pattern of seeing like it occurring through the generations is not typically there. Yeah. And so what I tell people is that, the risk of epilepsy in the general population, the risk of you having seizures, repeated seizures, is about 1%. And then for individuals who have known genetic conditions, so to speak, about 10%. And it's an evolving area. It's one that is complex. And most people, if they have epilepsy, they will not pass it on to their children, so to speak. In terms of genetic testing for the child, we're not really there yet.
So we'll focus on that majority of births are healthy.
And unfortunately, some of the more genetically based epilepsies can be very devastating for some of them. And so that, those individuals may be delayed and have other concerns. So those are, not necessarily, although not always, individuals seeking pregnancy. So.
But that is overall a very positive sort of
I think so, but it is an area that we need more work in. It is.
Yeah.
To better understand it.
As far as for individuals who are pregnant or are going to become pregnant, how does epilepsy affect the pregnancy, and how can a seizure maybe sort of affect the development of the fetus?
It's kind of interesting. That is an area that you'd think we would know more than we do at this point in time.
That's the answer a lot with epilepsy, I will say.
Well, yeah. But let's talk a little bit about that, though, in terms of, because it's important in terms of how you counsel people about the seizures, particularly when you mentioned earlier about, seizure control. So when you think of seizures, you divide them into seizure type. And so there's the what we call generalized tonic-clonic, or which are the convulsive seizures, grand mal seizures. These are all different terms that people use, focal to bilateral tonic-clonic. We want to avoid those in pregnancy. We definitely want to avoid those. You may have decreased oxygen delivery to the developing fetus if you have one of those. You can potentially affect the heart rate. So you definitely, the mother could fall, and there could be some injury for the mother or the developing fetus. So you want to avoid those. There was also a study done a number of years ago, and it was looking at cognitive outcomes, and it asked the question: well, did the fact that the mother, the pregnant person, have multiple convulsions affect the cognitive outcomes? And what they were able to show, it was a retrospective study, so they looked back. So it may have had some problems with that. Right. But they were able to show that the kids whose mothers had more than 5 convulsive seizures, grand mal seizures, in pregnancy, their cognitive outcomes, such as IQ, needs and special needs in school, were affected. So we want to avoid those. We definitely want to avoid those. But what about the other seizure types? We really don't have a lot of information about those. And so like, for example, what we call complex partial focal with impaired awareness seizures, those, there's really not much data, although there was, one of my former co-residents did a study, and she was not a study, she happened to be monitoring individuals during, on the labor floor, or they were being monitored, they were her patients, and they had these seizure types. And what they showed is that during those seizure types, there were some fetal heart rate decelerations, and which is a marker of fetal distress. And so in that little sort of like study that she published of these few people, was able to show that there can be an impact of those. But other seizure types, we don't know, like auras, myoclonic jerks, absence seizures. We don't really know what the impact of those are. And that becomes important. It's important in counseling because we don't have any clear negative effects to show of those. And then also sometimes the treatment can be nuanced. So, there's certain medications that we try to avoid, and that may be the medicine that controls the seizures, the big seizures, and so we think about that. So, for example, I'll just give you an example here. I may have somebody who has juvenile myoclonic epilepsy and has myoclonus, and I have to have them on a low dose of the medicine that I don't like to use, valproic acid, and because that's the only one that controls their convulsive seizures. But they still have a little bit of myoclonus, and I may have the patient live with that, so to speak, because I don't want to increase the dose of the medicine. So, but to answer your question, convulsions, grand mal, we avoid. We want to avoid those. The other seizure types, we want to avoid them as much as possible, but we don't have a lot of good information about the negative effects of those, or potential, I should say, negative effects of those in pregnancy.
So it sounds like it's everything with epilepsy. It's more research is needed on that piece, but the big takeaway is increased, seizure control, and then kind of looking at the risks and benefits of outcomes versus side effects.
Yeah, because there's no clear story to emerge that some of the seizure types I mentioned have a negative impact.
Right.
Yeah. I'm curious if I know that seizures can be really linked to hormones, and speaking to some people going through birth control and stuff, figuring that out with their seizure medication is an issue. Have you experienced people becoming resistant to medication or anything once they're pregnant, when their hormones are changing or going through IVF or something?
Yeah, I think that is a subset of people. It's a small subset of people whereby the seizures are really affected by the hormones. And I haven't really seen that, to be honest, whereby somebody the studies would consistently, in my experience, would consistently support that if your seizures are well controlled prior to getting pregnant, they're going to remain well controlled throughout pregnancy. And then there was a study that was done, actually, and it's kind of interesting. And I know some people have some issues with it, but it was following people seeking pregnancy. It was in India, actually, and it followed individuals, and it looked at people. It divided the groups, people who are hormone sensitive, reproductive hormone sensitive, and those who are not, and asked the question, well, what happened to seizure control in pregnancy when you follow those groups in parallel? And actually, the people in that study who had hormone sensitive seizures did better in pregnancy.
Oh,
so then you step back and you say, well, why would that potentially be the case? So when you think about the hormones, you got estrogen and progesterone. Those are our main female reproductive hormones. Estrogen has negative effect. They're pro-seizures. Like you see that in various clinical basic science studies, whereas progesterone, the opposite. Well, when you're pregnant, your progesterone is both hormones are, but your progesterone is really high. So that's one of the potential thoughts maybe as to why. It hasn't really been reproduced, but it's kind of interesting to think about it in terms of the mechanisms and why we see those patterns. But to answer your question, I have not seen people become drug resistant in pregnancy.
That's great. I feel like that does a lot for fear quelling as well. Yeah, just scary to go through such changes with your body, especially when you're already dealing with like this unknown entity that is epilepsy.
And speaking of kind of fear playing on that, I think when someone has a seizure while not pregnant, there's a lot of fear associated, I think, both personally, but also in terms of how their loved ones or partner might react. If someone were to have, one of the seizure types you're speaking of, the larger seizures, what should the person do? What should their caregiver do, or friends around them?
Well, I think the important thing is obviously the acute safety within that individual. And once the seizure has, we can ensure the family or the individuals around them has ensured their acute safety. And through the seizure, you need to alert not only your epilepsy specialist, your neurologist, whoever's taking care of the seizures, you need to alert your OB as well. Mm. And I think that's really important. And so oftentimes I will have, make sure that the OB is alerted, and they very often they'll have them come in and they'll, do an ultrasound to make sure everything is okay. So really you need to that plan in place. If you were to have one of the bigger seizures that we talked about, the convulsive seizures, alert your neurologist, epilepsy specialist, and your OB.
And if someone comes in for that, are the outcomes still usually positive, and that they can take a look and make sure everything's okay and potentially do something if not?
Yeah, yes. To answer that question, yes, the outcomes are positive. Most people do very well, even after having a big seizure like that. There is a potential concern, of preterm labor with that, and but for the most part, I've seen, in both in the studies and in my own clinical practice, the outcomes are good still. But it is important to know.
Are miscarriage rates higher in individuals with epilepsy who might be experiencing these seizures?
Yeah, there is a potential concern for miscarriages, particularly in somebody who's having convulsive seizures. But overall, you don't really see it in studies that have been done more recently.
So again, this is, I mean, for me at least, this is a lot of positive news, actually, to be honest, where
Me
there's
too.
appropriate concern, but, it seems like outcomes tend to be favorable.
They are. And I think they're, one of the things that we touched on earlier is pre-pregnancy planning, right? To make sure that you optimize seizure control, you're on the best medicines possible, you're taking your folic acid, and working with your neurologist, your OB, and making sure they're communicating with each other. All of that works together. All of that works to support you through the pregnancy and really work together to optimize the outcomes.
Yeah, I was kind of wondering about the process of like your neurologist and epileptologist and your OB working together, and sort of how do you recommend to patients that they sort of introduce this idea of like that their OB needs to work with their epileptologist and communicate? How do you suggest that patients maybe go about that process?
Well, I think it's for somebody who has epilepsy and they're thinking about getting pregnant, or I advise them to meet with the OBs beforehand, right? So obviously if we're planning it and you're pregnant, then fine. But as much as possible, I like them to meet with the OB to develop that relationship. And you're right, Sophie. It's not always, you sit here in a bubble and you say, oh, everyone should talk together. It doesn't always work that way. So I definitely, I'll proactively reach out. These days with certain electronic medical records, it's very easy to send messages. But, for the individual themselves, they oftentimes do have to be the advocate to say, and a lot of that's also, it's working together, because we'll touch upon a little bit about things you should do in pregnancy once you're actually pregnant. But, and it's also messaging, right? Because, you mentioned earlier about that individual that you met with who was told they could not get pregnant, and which is just, it's terrible to think that message. And I had somebody who was taking a medication that was the medication to control, and it was actually not associated with an increased risk in more recent studies of major congenital malformations. And they were told, you can't take that medicine. So that would support that if you're going to follow with an OB as much as possible, try and understand where they're coming from, and really you as the person with epilepsy taking the medications, meet with your neurologist as well. And I will say these days, with video EEG, not video EEG, excuse me, video visits. That's a pop that I like that, because you always felt bad for that pregnant person, right? Who's going to the OB all the time, and then they're going to go see me. It's really nice to be able to do a quick video visit, check in, and, see how they're doing. So
yeah, that was a question I had, because so many people don't have access, to experts where they live. Would you recommend folks, kind of reaching out saying, I'd love to have a consult with someone who has expertise in, reproductive health, fertility, and epilepsy?
I think it's a good idea. One of the issues with that really depends on where you live. So we're a little bit restricted in terms of video visits that we can do. And, I know that like in the pandemic, for example, all those restrictions were gone and people reached out. I think, it would be good. You're right. Because you want to talk to somebody that knows, right? You want to talk to somebody that is, and so, ask your provider, and if not, and within the state, if there's somebody, you could certainly do that. Mm-hmm. But it is a little bit more challenging with some of the licensing restrictions for that. But this is where different foundations can be helpful as well. Like the for example, like the National Epilepsy Foundation, they can be a resource. And then, I, along with Paige Pinnell, who's, as I said earlier, at Pittsburgh, and Elizabeth Girard, have been working with this Epilepsy Pregnancy Consortium. So it's an online And it was done very well. It was put together by a woman whose foundation has a foundation, an educational-based foundation, and their daughter had seizures. And so we're very interested in this. So that is a tool that can be used. So it's the Epilepsy Pregnancy Consortium. And it's web-based, and we worked really hard at updating that. So absolutely get a consultation if you can, and if not, use all the resources that you can to get the information, because it's out there.
When accessibilities can be such an issue, or just even knowing what they can ask the doctors that are available to them to sort of get an idea of what expertise they do have and stuff through these different resources could be very helpful, because I imagine that's an overwhelming process. It's already hard to find a doctor that you feel connected to and able to speak with and trust. So,
and just to confirm one thing you were saying too about epilepsy during pregnancy. Let me know if this is correct. That your in general seizure control and seizures tend to stay the same through pregnancy, and that you don't see a big shift in that outcome.
Right. And one of the things that's important about that, though, is that that's where, but you do need to actively follow. We touched upon this with your epilepsy specialist or neurologist. And so there has been work showing that, again, I keep saying this, seizure free, that 9+ months, you're likely. But that's nuanced, right? Because it does require actively being followed. So when you look at all the anti-seizure medications, what we know is that their concentrations or blood levels, that is the amount of those drugs in your blood, drops.
Right.
So as and it drops, years ago, I wouldn't want to be that active about following those in the first trimester, because we wanted to make sure that you got through that where the organs and everything are developing on the lowest dose possible. But, studies now really show that all the medications drop pretty dramatically not dramatically, some more dramatically than others, but they all drop beginning in the first trimester. So it is really important that you have a level or concentration that's established, preferably before you get pregnant, if not as early in that pregnancy as possible. And that's going to be your target. And then you follow that throughout the pregnancy. And most individuals will end up on higher doses towards the end of the pregnancy than they were on before. So that's a really important piece of that. And, there was a study that Kim Metter at Stanford and Paige Pinnell led, and it was a multi-centered study all over the U.S. at multiple sites, and it followed individuals. And there was an article or analysis that Paige did that was published, and what it showed is that most people have good seizure control, but it also showed that most of them had medication changes. But the one thing when you step back about that sort of study and you think about is they're all done at places like Columbia, like Stanford, like Pittsburgh.
Right.
Well, what about the people out there who are not at those, academic epilepsy focus centers? And so, so the message should be the positive one. Your seizures will be well controlled, but you need to actively follow that to ensure that happens, because it does require active anti-seizure medication level monitoring and dose adjustment if necessary.
That would be very interesting to look just research-wise at, the variations in geography and socioeconomics and how it affects, these outcomes. And I think that's actually something I'm curious about. Do you see kind of geographic variation in birth outcomes like you do normally, based on things like socioeconomics and race in association with epilepsy?
Well, I think you definitely see this studies when you look at that. I mean, you see it in terms of anti-seizure medications. They may be, although that's getting less, as some of these other medications are better understood. I mean, years ago, it was a much, much bigger issue. And then, obviously the outcomes, I mean, I'm not aware of that, but I would certainly assume that it would be affected if you're not, for example, following with somebody who's really comfortable with that and you're not getting that, you're not getting the levels, or the individual who loses their insurance and back and forth, and they're following with the OB and at the OB, and they're not aware that the neurologist, epilepsy specialist isn't involved. So, but again, that's back to, one of the first things we talked about, right? Dissemination, getting that message out there that you can do well. People can do well, but there's certain nuances or active things that we in the healthcare community need to be doing to ensure that.
Yeah, that is, I'm sure, a major difference. It would be interesting to look at those studies like geographically, but good for getting the message out to healthcare and also to the patients that can ask to have their levels checked and bring that up if they feel like that's being ignored. That's something that's fantastic to know. Can you speak a little bit to some of the risks of the various medications on the fetus? I know you mentioned that there's like a large variety, not to scare people here, but good to know.
Yeah, so when you think about risks, you divide them up, right, into different categories or different ways. So the one general area that's received a lot of study is what we call major congenital malformations. Well, that's kind of a mouthful. What is a major congenital malformation? Basically, it's a physical malformation or physical problem, so to speak, that the baby may have that either interferes with function or requires surgical correction. So there's different kinds that you can think of, like effects on the heart, on the spinal cord, like with a neural tube defect, or cleft lip and cleft palate. These are a variety of different so-called malformations that you can see. Now, what's really important to understand is, and something I talk to everyone about, is that risk isn't zero in the general population. It's not. We've done a lot better than we did years ago, particularly since folic acid, for example, has been supplemented in grains and cereals and whatnot. And there's been a big public health push to have the general population take folic acid. So it's about 1% to 3%, or 1 to 2 point, like in the 1% to 3% range, depending on the study in the general population. When you look at individuals with epilepsy and their children or the babies they have, the risk is overall probably about double that. But then you get into the nuances of the medications. Keep in mind when I say that sounds kind of frightening, but keep in mind that's all the medications, okay? So what do we know about the individual medications? Well, the medication that we want to avoid, because it is associated with an increased risk of major congenital malformations shown repeatedly, is valproic acid. The brand name for that is Depakote, Depakine, valproate. There's, depending on, there's that's a generic or the brand name for that medication. And that has consistently been shown to be associated with the highest risk of congenital malformations. And the ones that have the lowest, and I was so fortunate recently and just so privileged to be involved in a systematic review or guideline that was done with the American Academy of Neurology, American Epilepsy Society, and the Society for Maternal Fetal Medicine. We have this wonderful group of, individuals, and we all worked together for years to better understand this, looking at it. And what we did with that was we asked several questions, and we looked at it by the anti-seizure medication. How did it vary across? And so in looking at that, you could see that valproic acid had the net negative. And what we were able to show is the ones that had the most positive outcome, that is the lowest risk, was lamotrigine or Lamictal, levetiracetam or Keppra, oxcarbazepine or Trileptal. And I'm giving you the generic and the brand names for each of those medications. And those numbers were in like the 2% range, like So overall.
And those are very common. We hear those all the time.
Yeah, and they're commonly prescribed. And certainly when you look, remember we talked earlier about the prescribing practices, how they changed. Those are the ones people are taking more now compared to years ago when they would have been taking other medications. So, there are within that medications that are associated with the lowest risk, and then the valproic acid. So when thinking about risks, it's very much driven by the anti-seizure medications that they're on. One thing with those particular risks is there's a lot of medications out there that are relatively new. Like, for example, like a medication that people are using a lot now is cenobamate or Xcopri, particularly for those more difficult to control seizures, drug-resistant seizures. We don't really have information about that. And so how do we get that? And it's important to understand how we got the other information to help us figure out how we're going to get more information we need. And so throughout the world, there's different what we call registries or registers. And there is one in North America. It was actually the first one to be established. And what you do with that is that the individual reports themselves. In the US, the individual reports themselves. In Europe, the physician can do it. And you get enrolled in those very early. So if you're somebody who gets pregnant on an anti-seizure medication, you want to help contribute to this and figure out what the outcomes are going to be. And then they follow those individuals through pregnancy. And they follow the babies, depending on what the registry or register is, they'll follow it for variable lengths of times. And that's how we've gotten the information. That's how we're able to sit here and say, lamotrigine, levetiracetam, 2 to 3%. That's how we've been able to do that.
Super important people get involved in that. And I think this also speaks to the pre-planning that you were speaking of, because this does mimic other conditions, people that have, are taking something for mental health issues or whatever it is, and in their planning stages, or if they're of reproductive years, their, physician might suggest, if it works similarly, to maybe switch if you might get pregnant. And so my question comes, if you are on something like Depakote and, you find out that you're pregnant, just like, I was having a glass of wine, had no idea I was pregnant. And then I was like, oh no, what's sort of the immediate thing someone should do? Should they be concerned or, just really kind of check in with their doctor immediately?
Check in with your doctor immediately. And a lot of that will depend on why you're on it. I will say that if you look around the world, particularly in Europe, there's like very strong regulatory statements about not using that. And it is considered, like, for example, in Europe, as I said, very strong regulatory statements about not using it. In the US, we tend to have it more as this is, class. You avoid this. You definitely avoid this medication. But if you're on that and you get pregnant, you should definitely, and you want to be careful. Again, why are you on this? Why are you a reproductive aged individual capable of getting pregnant? Why are you on that? In 2024, why are you on that medication first line? I would hope that it wasn't the first medication that you had been put on, but if you are, you need to address that. And then you need to address, should I transition to something else? Because again, we got to balance that, right? We don't want you seizing. And then what is the dose you're on? Because a lot of those studies with that medication, clear dose effect. That is, the higher the dose, the more negative the outcomes are. So you definitely should check in right away with but to your point, Heather, though, it really supports the need for pre-pregnancy planning. So much of our community, we're focused on the physical, right? The major congenital malformations. And then some people start asking, well, what about the cognitive effects? Like think about it, like the first trimester, that baby's organs are developing, but the second 2 trimesters, baby's growing in size and the brain is developing. So what are the impacts of these medicines on the developing brain? So there's a number of studies that have looked at this, and there's a number of people in the field that have done just incredible work in this. And a shout out to Kim Metter at Stanford, who's just been so important in this area. And what that's done is prospectively follow individuals who were pregnant and followed their kids. And again, this is on multi-centered studies that looked at this and followed those kids through the age of 6. Okay. And they do IQ testing along the way with the main outcome variable, the main outcome being the IQ cognitive outcomes at the age of 6. And what you see with those studies is that valproic acid, again, negatively. So those individuals whose mothers took valproic acid were more likely to have lower IQ than expected, after controlling for all the factors that influence IQ. And also you see higher percentages of autism and autistic traits. So that is another reason that one should absolutely avoid that medication. And the other thing that was shown in those studies is that folic acid positively affects the cognitive outcomes. So that's another area that many people that they hadn't thought about, but it's really good, well-designed studies to support that there is a potential negative effect of that valproic acid on that, developing brain and the cognitive outcomes.
Can you still breastfeed on medication? How do the risks apply there?
The story there is breastfeed. If you want to breastfeed, go ahead and breastfeed. And so, again, how do we learn this? We learned it through all these studies. And, those studies I just talked about with cognitive outcomes, they looked at individuals whose mothers breastfed versus those who did not. And the breastfed group, even if the mother was taking valproic acid, the one that we've talked about, they did actually better than the kids who did not breastfeed. So, I counsel the individual. I talk through that. Do you want to breastfeed? If they want to breastfeed and it's something that works for them, and I fully support it. I do think, and I'm seeing this less than I did, say, 20 years ago. Again, this is where you got to get all your providers on board, right? Your neurologist, your OBGYN, and the child's pediatrician. Because, and I will encourage the people to meet with the pediatrician beforehand, because you want to be comfortable, let them know what your experience is, and make sure if you're going to breastfeed. And I don't see this again as much as I used to, although you told me a story about people being told not to get pregnant. I mean, I do remember like years ago, individuals coming to me saying that the pediatrician said they couldn't breastfeed. And in one particular case, they said, I won't take care of your child if you breastfeed, which is just really disturbing. But again, I've done a lot of work here at Columbia with the nurses, like the postpartum nurses, right? And the OBs, because I've gotten calls over the years from individuals, they've delivered their baby and the nurse comes in. And again, I'm not disparaging. It's just where this dissemination and information is important. But an individual treating that person in the postpartum floor may not be aware that they can breastfeed. And they come in and they say, oh, you're on a high dose of this medication. You can't breastfeed. So,
But see, that's another good thing for on our end patients to know too, that's a red flag in your pediatrician. If they say something like, I won't treat your child if you're like,
right.
There might be worth getting a different opinion on that.
Yeah. And since we're all women here too, it's just another kind of illustration of, the misinformation and lack of research and advocacy around women's health.
It's
totally
insane. To end us kind of on a positive note, do you have any sort of uplifting success stories of patients conceiving and having healthy babies? Or is that just like so your standard that they're all uplifting, healthy success stories?
I gotta say, most of the individuals, as we said earlier, again, most have normal, healthy babies. there's definitely, but I'll give you a couple of stories where, there was an individual I took care of for years. She was on multiple medications and was in a relationship, and she was on, as I said, she was on multiple medications. Her seizures were really hard to control. And she contacted me and she said, I'm pregnant. I was like, oh, goodness. She was on lots of different medications and we followed her really closely. And, she had a normal, healthy kid. And this is somebody who wouldn't have thought that was going to occur for her. And despite being on different medications at relatively high doses, she had a normal, healthy kid. And so, we as a community want to do the best we can to increase the chances of that. But she really highlights to me that, most people do have normal, healthy babies. I had another individual that I took care of who was on lamotrigine, associated with good outcomes. And she had one pregnancy, the first pregnancy that, whereby there were clear malformations, clear issue concerns. And, and she had lived with that. In that particular case, it was a devastating outcome. So she had an abortion. And then we had a long conversation. Was it the lamotrigine? Was it? And, we talked, and it was controlling her seizures. And I said, these things can happen. As we talked about earlier, the risk in the general population is not zero. So she stayed on lamotrigine, and then she went on to have 2 normal, healthy kids after that. So,
Wow.
So there's many, many, many stories. And, I think about all the individuals I've worked with over the years, and just, it doesn't get, I got to tell you, Sophie and Heather, it doesn't get old. It doesn't get old. Like taking somebody, getting to know them, working with them through their pregnancy, and then they're sending me the message, thank you, Dr. Pack. I have this beautiful, healthy baby. And, it's really a very fulfilling part of my clinical practice.
It's such a reminder, like Heather was saying, just reproductive health and everything in general, and the lack of education on that, and what an impact it can make when we have fantastic doctors like you. And I hope too that people listening to this episode, if they don't have access to specialists, we're able to take something from this that they can bring to their next appointment and talk about. So thank you so much for being on.
Thank you so much. We've talked a lot about women or people who have childbearing parts. In terms of men who have epilepsy or who are, the person that's contributing the sperm, is there an issue there in terms of medications for them and how that might affect either outcomes or fertility?
I'm so glad you brought up that point, because it really is important to address that. Some of the medications, remember earlier we were talking about fertility, and I said that some of the newer medications are better in terms of fertility outcomes for the, the female, so to speak. Well, some of those same medications that negatively affect females also affect males. Okay, so so some of there are some medications. Again, you hate to keep bringing up valproic acid, has been associated with lower sperm count, as well as abnormal sperm. So again, if you're the man, so to speak, or the male, and you are, with your partner actively trying to get pregnant, it's not happening. After 6 months, follow up on that and get that evaluation. I will bring your attention to the fact also that there's been some studies, and there's been like some work that's been done in Europe looking at valproic acid and cognitive outcomes. And there's some warning that if you're a man, you're a male, and you have a child and you are on this medication, that can negatively impact the cognitive outcome of that child. I have some concerns about that, and I'm not really sure, and you guys will appreciate this. Somebody said, wow, it's amazing. was all those years this data was evolving when it was for reference to women, females, individual childbearing potential. And now you have a potential signal with males, and we've got a warning right away. So, but it doesn't necessarily, and a number of us who have been involved in this field and done work, and there's some editorials about this, it doesn't entirely make sense because it's not thought to be something that occurs at fertilization. It's thought to be secondary to the ongoing exposure to the medication. So that doesn't really, it's not clear. And, I'm all for research. I'm all for warnings when there needs to be, but they need to be well thought out and data driven. And that, I don't know about that message.
Okay. Well, thank you again, Dr. Pack. Thank you, Heather. It was fun to have you.
So fun to be on. I learned so much. So thank you, Dr. Pack.
Yeah.
And everyone can hopefully check out some of the resources that Dr. Pack mentioned. We should have them linked on our website or in the comments. So thank you guys.
Yeah. And thank you for doing this because getting, like I said, dissemination, let's get that message out there.
Thank you to Dr. Pack and Heather for joining us today. And thanks to our amazing sponsors, UCB, for making this episode possible. Go to thecameronboysfoundation.org for resources and be sure to check us out on socials.